Drug overdoses are now the leading cause of death for people under 50 in the United States. A New York Times report citing data from across the country says more than 59,000 people likely died of drug overdoses last year, the largest annual jump ever recorded in the U.S. And in Massachusetts alone, as you probably know, nearly 2,000 people fatally overdosed on opioid drugs last year. That's why in April, the Massachusetts Medical Society came out in support of supervised injection sites, where addicts can shoot up using clean needles with doctors watching over, ready to administer overdose drugs if necessary. Now, some local lawmakers are looking to rewrite the rule book for tackling the epidemic. State Senate has proposed a study to look into the injection site issue, and members of the Boston City Council have called for a hearing on the issue. Joining me are Dr. Henry Dorkin, he's the president of the Massachusetts Medical Society, and Dr. Robert Barretts. He's an internal medicine specialist at Beth Israel Deaconess Hospital in Milton. Good to see you, Doctor. And Doctor, why did Mass Medical take this position?
We took this position because we were trying to look on all fronts as to what options were out there to try to lower the deaths. We've made some headway with education. We've made headway with decreasing the number of prescription pills that have gone out. And while the death rate has slowed in terms of increases, it's still going up. We looked around to find some other options that were working in other venues and felt that we should look at them closer.
You voted no on this thing, correct?
I did.
Why?
Because I think it's a bad idea that's poorly executed.
What does that mean?
Well, there are ethical issues about using street drugs in any kind of medical setting, not even knowing what they are. Number two...
Well, they'd be using them anyway, would they not?
Yes, but under medical supervision, I think there's a conflict between our duty to a patient and what the patient's trying to do. And that's a problem that I have. It's a slippery slope.
Do you not agree, though? I don't know enough to understand the ethical issues, but do you not agree that the experience so far in places, for example, like Vancouver, they say since 2003 when they started doing this, they've reduced overdose deaths, lethal overdoses, by 35%, and there hasn't been one lethal overdose in one of these supervised sites. Is that not good enough reason to try this?
Well, I think the experience in Canada is far different than what we have here,
Why?
as are their laws and the other things that go on there. I mean, the center there has 400 to 500 people using one center in a day. I don't think we're going to see that in Boston.
You know, when I talked to people about this today, knowing you were coming, Doctor, the major argument I heard about it was it's sort of giving up. I mean, let's see, here's Charlie Baker, by the way, who says he's sort of agnostic, wants to hear more, but here's what the governor had to say about the proposal.
Well, let's put it this way. It's pretty unorthodox, but I'd like to see why they came to this conclusion and read about it and what they think the benefit of it might be. My goal is to try to keep people from becoming addicted in the first place.
And that's a variation of what I heard. Not so much there, he didn't say giving up, but this is essentially a strategy, prevention, not using to begin with, is where you should be focusing your attention, not saying they're going to use, so let's make it as safe as possible. What's your reaction to that?
Well, my reaction is that we really have to attack this problem on all fronts. And we are working on trying to. Doctors are now writing for far fewer prescriptions for narcotics and for smaller amounts than we did in the past.
Is that because of what happened on Beacon Hill? I know you were part of that discussion.
It certainly was a group effort from the governor's office, the legislation. The medical society had a role to play there. We also did a lot of work in terms of physician education. We've made CME modules on physicians, on pain and narcotics available freely for anyone. They don't have to be members of the medical society, and over 10,000 different courses have been taken.
Do you think, you know, I was in New York City right around the time needle exchanges were as contentious as the debate clean needle exchanges as I think this is probably going to be. I think if you spoke to most public health people in New York City, they would say one of the things that brought the AIDS epidemic under control in the 80s, I believe, was this clean needle exchange. Would you have been against that at the time, Doctor?
No, because they're entirely different issues.
Why?
Because this has to do more with injecting drugs of unknown street quantity and potency, and that had to do with preventing a disease that we had a pretty good idea of what the spreading factor was.
But can we return to this unknown, you don't know what the drug is? Isn't that engaging in denial? Because I'm not suggesting you would know, but if they are not able to use it in a safe facility with some medical oversight, they're going to use it outside the facility with no medical oversight. It isn't like you're going to eradicate this drug use by saying you can't do it here, no?
Well, I'm not sure it's so safe in that facility, nor is it being rolled out the way it was proposed. And
How would you roll it out?
Let me say first, I don't disagree with Dr. Dworkin about most of what he said. We're not in favor of, free-for-all with drugs or any of those things.
Obviously
and
not.
all the things that have been done are good ideas in their own place. I think this idea is got some problems with it, which is what I brought up at the Medical Society meeting. And it's basically going to be an uncontrolled experiment on human beings where it's not being monitored by a safety review board.
How about that issue, the monitoring issue? Does that concern you?
Well, first of all, a couple of years ago when I first heard about this, I was skeptical as well. One of the things they taught me at Hopkins was to look at the data. And so I looked at the data, and what I see is kind of compelling coming out of Vancouver. But, this is putting together a commission run through the Department of Public Health, and we're more than happy to work with them to look at all the concerns that people might have about what might go wrong.
Including concerns like his.
Including concerns like his. I mean, many of these clearly are not novel. I'm sure that there are issues in Vancouver and in Australia and in Europe, and we will take a look at what they've done and how well it's worked for them, and we'll modify those criteria in order to make sure that we do this in a safer manner.
Doctor, I'm the only layperson here. I'm a big user of what you do, but I don't provide the kind of care you do. When you've got a crisis like this, of this epic kind of proportion with so many people dying, and the stories are so painful, don't you decide to be less risk-averse on something like this than you might be otherwise because the alternative is so horrific?
Well, I think there are other alternatives than this particular type of method, and that's my issue.
But can it be part of a strategy? I mean, obviously, I assume your position is this is not the cure-all, so to speak. I mean, as a pun, this is a part of a strategy to deal with a horrible epidemic, no?
Well, but the cost of dealing with it this way is immense. The potential benefits are not going to reap large quantities of benefit the way it's been laid out and the execution plan that was proposed.
Not one death, and wait, in all these places that are used, not one single death in the facility. Where's the risk? I'm sorry, I just don't see it.
Well, first of all, there was no concrete plan on how this was going to be done when the Medical Society voted on it. They merely voted to endorse the concept. And I brought up some very real problems with how the concept could be executed. For example, someone off the street can come in with whatever drugs they have, in whatever quantities they have, with however many other people that are there, and overwhelm the facility, all pass out, and I can't believe that not one of those people is going to die in that facility under those circumstances.
But they haven't.
Well, I said, if it's open to the public and they can walk in, that's what could happen. Also, when they walk out, they get in their car, you can't stop them, and drive, and cause an accident and kill somebody or run into a bus full of children.
15 seconds to respond to that, and then we've got to go, Doctor.
All the concerns that people have are important for a task force to look at and see how they are going to be addressed. As I said, I believe many of them have been addressed in other venues. There may be a couple that they have glossed over that we can then work on. But ultimately, as you point out, absence of deaths.
I hope you're on that task force. Good to see you, Doctor. Thank you so much.
Thank you very much.
I'd be happy to sit on it.
I'm sure you would. Pleasure, gentlemen.
Thank you.
Thank you.